Good morning. My name is Tracy Trypuc, and welcome to Your Health Matters. Many people in our country have raised questions about the Ebola virus. Ever since the first patient arrived in Texas and was confirmed to have Ebola on September 30th, many in our country raised questions about contracting Ebola virus and if our healthcare system was prepared to handle it. The public has been alerted, and many have shared concerns about this disease. Today, I wish to discuss with one of our leading experts about Ebola preparedness and response that is underway here in Suffolk County and specifically at Stony Brook University Medical Center in Stony Brook, New York. By doing so, we hope to share important information and allay any unnecessary fears. Before I introduce my guest, I'd like to share some information about Ebola. On October 16th, Governor Cuomo outlined the Ebola Preparedness Plan for New York State. Additionally, the State Department of Health has issued commissioner's orders to all hospitals, diagnostic and treatment centers, and ambulance services in New York State, requiring that they follow protocols for identification, isolation, and medical evaluation to patients requiring care. Countries being monitored include Liberia, Guinea, Sierra Leone, and now Mali. The governor designated 8 hospitals originally and now has added 2 more statewide, including, I'm not going to actually name all of them, but including Stony Brook University in Suffolk County. With this information, I have the pleasure of introducing Dr. Reuven Pasternak. He is the CEO of Stony Brook University Medical Center. And now I'd like to welcome my guest, Dr. Pasternak. Welcome, Dr. Pasternak. Thank you for coming on the show and discussing this important topic.
Thank you. Glad to be here.
Thanks. I'm happy to have you here to discuss your efforts here in Suffolk County and at Stony Brook University Medical Center as a designated hospital in New York State. When you and your colleagues first became aware of the events in Texas, what was your initial reaction?
Well, actually, our preparations had long preceded the events in Texas. So when the concerns first arose about the events in Africa and the prospect that we might be having people coming back, we began preparations with our medical team, administrative and operations team, and also with the Suffolk County Health Department. And those preparations included identifying what we would need to do to be able to treat these patients and what processes and policies we would have, what protective gear and so forth. So we had prepared for that eventuality before the events in Texas. What we did when that event occurred was to look at what had happened in Texas and say what would have happened if that same patient had come to Stony Brook and reconstruct those events. And while it was unfortunate that the events in Texas happened as they did, what we discovered was that had that same patient presented at Stony Brook in the manner they had presented in Dallas, that we would have in fact hospitalized that patient on the first visit to the emergency department, and that the nature of the protective gear and practices that were required to prevent the transmission to the 2 nurses was already in effect in our institution as well. So it gave us some reassurance that we were on the right path to be able to treat it, but it also made us aware that we had to be very vigilant and had to do even better yet.
Yes, I think that was one of the lessons learned from that unfortunate incident was that, and I'm glad to know that you already had those measures in place, but that everyone needed to step up and look at their policies and procedures and make sure that, you know, if someone presented with certain symptoms in the emergency room or wherever in a clinic, et cetera, that the measures were in place, that they were going to be hospitalized right away, and that the staff had not only had the training to utilize the protective, personal protective equipment, but also had the correct personal protective equipment available for them. And so I think that was like a wake-up call for all of the hospitals throughout the country.
It was. Hospitals that thought they were prepared went back and re-examined what they had done and found opportunities to improve. I think it also had people looking at the two institutions that had successfully treated Ebola patients, the University of Nebraska and Emory. And there we had examples of patients who had been very ill, who would have died had they stayed in Africa, who received intensive treatment, were cured, and whose staff were able to exercise appropriate precautions without transmission of the disease. So we had both a positive model to use as well as the negative.
Yes, that is important. I noticed that you have been reaching out to the public as you were doing here today, and again, thank you for that. Why do you think this is important? Do you think that it helps build trust with the public in this situation?
So we felt that we had several obligations we had to do. The first obligation was to prepare to treat a patient if a patient presented themselves, to do it in a way that protected the staff, but also to provide perspective of what we were facing. So we have not yet had an Ebola patient on Long Island. We wanted people to understand Ebola, what the true nature of the infectivity was. There were concerns that there were large numbers of patients who were waiting to come in, and there weren't. And also to let people know that there was a system in place to address patients who might have concerns, and that we were also working collaboratively across the region on that.
Right. And when you say you're working, well, let me get to that in a minute. So you are one of the now 10 designated hospitals as a regional source. Can you tell our viewers, I'm sorry. Okay, you said that you started working proactively right away and actually prior to that first incident. But you have a task force that's led by your chief medical officer, Dr. Joseph, and Director of Emergency Preparedness, Leo DeBobes. Yes. And so they are very active in this preparedness that you are doing at the hospital? They
are. So they lead a team that includes physicians, nurses, infectious disease specialists, operations people, law enforcement as well, public relations, every aspect of operations that might touch the ability to prepare and manage a patient with Ebola. The group meets several times a week to review. We also have been preparing our staff with drills, so we have 370 people trained to use the high technology isolation units and isolation protective gear, and that training is ongoing.
Okay. And so when you mention that that you are meeting, some of the people that you're in communication with are the state and county departments of health, the CDC, and other regional agencies here in Suffolk County.
Yes, it's been an extraordinarily collaborative effort. It's been very gratifying. So twice a week under the auspices of the State Health Department, all the hospitals that have been designated as Ebola institutions have a conference call. And we share what we have encountered in our preparations. When Bellevue had a patient, they were able to share with us what their experience was with actually treating somebody, so we were able to learn from them. The state has facilitated those institutions that need to get supplies. And then we have also had inspections by the state, and in some cases the Centers for Disease Control. And so that aspect has been very good in terms of ensuring the latest information and preparation is available to everyone.
That is great when all the agencies work collaboratively together, and that's reassuring to the public.
They have, and they've made sure to cut through any red tape that might be encountered in terms of regulatory requirements, so that we were able to get things done very quickly.
Right. And these are things that the public needs to know, because I think that one of the things that you read about in the paper or you hear on the news is that there is some confusion, or there is still some fear as to how are you going to treat a patient, how they're going to be transferred, how long are they going to be treated for. And so by answering these questions and explaining how it's like an interagency and collaborative effort with all of the agencies and the state, the county, really does kind of help educate the public and help them understand that there are many, many people involved in this process. So, you know, I think, you know, I applaud everyone's efforts.
Thank you.
So would you please discuss some of the types of drills and training exercises that you're utilizing? I know you just mentioned about the personal protective equipment. A lot of people, they hear PPEs, they don't understand what personal protective equipment is and that there are many different types. And that was one of the issues also down in Texas. So, and they also might hear doffing and donning. And, if, you know, of course, doffing is putting on, doffing and donning. If you could please, you know, tell our audience about the putting on and the taking off of equipment. Sure. And that the personal protective equipment is there to protect the healthcare worker, and that there are exercises involved that even have changed even just recently.
So as you say, it's been an evolution in terms of the protective gear. At an early point in time, we went to using the most sophisticated gear ahead of what the CDC had recommended. Now the CDC recommends that also. The goal is to ensure that not only is the patient protected, but the staff are protected. The protection is designed to ensure that there's no exposed skin. So when the individual's in the room, they're completely covered, and not only that, but the air that they are breathing is filtered. So if the patient, for some reason, were to cough or have some other exposure of the virus, they're protected by the air filter, even though it's not an airborne virus, the way the flu is. And putting the gear on is an exercise that can take 20 minutes in itself. So when we have trained the staff, we train them with a partner. So somebody is there watching you put it on with a checklist to be sure you're putting everything on in the correct order. What's even more challenging is taking it off correctly. Right. So you have zones in the room. The hot zone is the zone where the patient is located. The warm zone is the anteroom right outside of that, and the cold zone is a regular zone in the unit. And one of the practices that takes more time is to be sure that as somebody is taking off the protective gear, they're taking it off in such a way so that if there are body fluids on the gear, it doesn't then go on to something else, which can cause infection. So individuals get an initial 2-hour instruction how to do that, come back for a repeat instruction, then everybody is constantly drilled again just on that protective gear. We've then had situations where we have somebody come to the emergency department and give a history that we give ahead of time, a history that should cause somebody at the entrance to the emergency department to get suspicious and declare this person of concern. They have consistently done that and done that well. And then that sets the drill in motion of having them go back, people putting on the gear and being sure that we can do this, put their family aside, and then transport them to the room if that were to be needed as well. We also have a system set up so that if we were to have a patient, we have everybody working in teams so that when a patient is being cared for, there is a team of nurses and a physician, and they will be the only people who would care for that patient. They would not care for any other patients, and other people would not care for that patient, so that we eliminate that as a factor in transmission as well. Okay.
So now this team, they would work, say, what, a 12-hour shift, and you would have a second team for the next 12-hour shift. Could you explain that?
We actually only have them work a 6-hour shift
because of the fatigue.
The fatigue, exactly. It's staying in the suit for more than 2 hours. It can be a challenge. Some people had said 4 hours. We think 2 hours is about it. So the teams switch out during that time. They'd work a 6-hour shift. And so that means in a 24-hour cycle, we would have 4 teams caring for that patient. It's a very personnel-intensive exercise. When a person finishes that shift and they take off the gear, they then have the opportunity to shower, clean themselves, get into a new set of clothes. So it's not just the 6 hours that they're taking care of the patient, it's time before and after. We also do the same thing for the EMS team, the transport teams. And we have ambulances and emergency transport squads that are specially trained to transport patients who may have Ebola, so that if we get a call about a patient of concern, we can pick them up from another isolation area, bring them to Stony Brook, and during the entire time that they come through, they will be protected, as with the public, from exposure.
Okay. Now, where would they stay at Stony Brook? Do you have a special isolation area different from the regular isolation area?
We do. So it starts in the emergency department. We have one room that's designated as the Ebola receiving room. We have 2 other rooms that can be used if need be, if we had more than one patient. That room has all the equipment in it and a cart that has medical supplies in it. Once a patient goes into that room, there's a clear pathway to be used by people to go in with protective gear. They then would go from there, after further determination, if we feel they have Ebola, to a room that's prepared elsewhere in the hospital. And we have actually 2 rooms, so one is the first one to be used, the second if we absolutely need it. And these rooms are located in an area so that there are not other patients in the immediate vicinity, so you don't have patients in rooms on either side.
Okay. So I think then we've probably discussed the content of the Commissioner's Order in Article 28 that just came out, which focused on the personal protective equipment. So probably can move on from there. But that is how not just important, but I mean, this is like from top down. I mean, from the government, making sure that everybody is also following all of the same procedures.
That's correct.
And so that's very important. And you're getting the most current information on a timely basis. I mean, it's coming to you as soon as they get it. They make sure that you get it.
It's coming real time, 24/7.
Okay. So can we discuss briefly symptoms of Ebola? Nausea, vomiting.
So fever,
Right.
nausea, vomiting. It has been determined that patients who are symptomatic, who have Ebola, who become symptomatic, do so after having developed a fever, usually above 100 to 101 degrees. The symptoms, as you describe them, are not specific to Ebola
Right.
alone. So what has to raise your index of concern is, where have they traveled? Do they have a history of exposure? Not everybody, obviously, who presents with those symptoms or somebody that needs to be watched. So we look for the constellation of travel, exposure, and level of symptoms, and then make the determination through the health department about who needs to be watched. If somebody is felt to be at risk but they're not symptomatic, we can just check in with them on a daily basis, and then otherwise we do it on the history and physical exam. We have had some patients who presented who we thought might be at risk. They have all tested negative, as have the vast majority of people who have shown up for facilities in New York City.
Okay. And the incubation period, which is the exposure time till that they can show symptoms, is 2 to 21 days.
That's correct.
Which is why those that are being monitored for 21 days.
Right, and 21 is conservative. If you haven't developed it by 21, you're not going to.
Okay. Now, some of these symptoms can mimic the flu. Is that correct?
That's correct.
Okay. And so for people who are concerned about Ebola, I saw that you had written an article in the Three Village Times, and you said one of the things that people can do would be to get their flu vaccine. And last week we did a little segment about the importance of getting the flu vaccine. I actually got my flu vaccine at Stony Brook. So, and so, you know, it's important for people to keep, I think, for people to keep things in perspective. You know, that over 200,000 people are hospitalized every year because of flu-related problems, and that 5 to 20% of the population does get the flu every year, and that can cause all kinds of problems. You know, lost time at work and spreading the illness to other people. So even though the flu is not Ebola, your chances of getting the flu are much greater than they are of getting Ebola.
Yeah, I'm so
Right.
glad you raised that point, because that's what we have raised with our staff also. We had town halls to speak with our staff to reassure them about what we're doing with Ebola, but then we ended with that point of saying we have not had anybody with Ebola yet. It's not likely that we're going to, but we know for sure that thousands of people will die from the flu in the U.S. each year. And the number of those people are people who didn't have to die had they gotten the flu vaccine. So at the end of these sessions, we ask everybody to raise their hand and ask who has gotten your flu vaccine. It's mandatory at our institution. And if somebody hasn't, we tell them you're at much greater risk from the flu than you are from getting Ebola. So that lesson is well taken.
Yes.
Prepare for the common as well.
Yes. So I think that is very important, because we've only had 4 or now 5 Ebola patients, right?
Right, and only 2 who contracted Ebola in the United States, and they were from some care providers.
They were healthcare providers, and yet when you look at the numbers of the flu vaccine, so I'm just trying to put it in perspective, because again, I understand people. This is something new. People don't really understand, and I'm just trying to let them see what the numbers are. And you're right. It's usually going to be a healthcare worker that does contract Ebola if they do. So this is really just to let the public know what the facts are about Ebola and the risks, and that if somebody were to contract it here in the U.S., or if another patient came from Western Africa in one of those countries, that you have all of the preparations are at the ready to take care of any of those patients, and you continue to train.
We do.
Yes, which is very very good to know. That, and what is it that they say when excellence is from continuing to practice.
Right.
So I'm glad that you do that. One other thing that you mentioned in that article was, here, I have it right here. One of the best responses to this outbreak is the call for a renewed commitment to the health of others worldwide. And with the arrival of Ebola in the U.S., people deeply understand how our individual health can be impacted by global health. Would you like to speak about that for a moment?
So when you think previously, somebody might have thought what happens with infectious disease in West Africa doesn't affect us here. Now we know it does. It's from one plane right away. And so we should be concerned, not just because there should be a fundamental concern for our fellow man, but also from the standpoint that we are a very close interconnected community. So what we should be doing, the best preparation to prevent the spread of Ebola, is to stop the spread at its source, to be proactive, to give support to those areas in Africa or other areas of the world when they face Ebola or other infectious disease, and to be an active part of the containment and cure and not wait for it to reach our shores.
I couldn't agree more. I really, when I saw that, I went back to one of my old Paul Farmer books, and there's a quote from him that says, "What the American public thinks is very important to the future of global health. Many people are moved by the idea that there is unnecessary suffering in the world, and we could do a lot to stop it. We have the technologies necessary to stop most of the suffering." And I really do agree that this has brought light to the fact that this is what's going on in other parts of the world. And now, all of a sudden, we are seeing it here. And, people need to recognize that there is so much that we can continue to do, and we should continue to do, to help those that are suffering in other parts of the world. So I very much, applaud your statement. And I thank you for the work that you are doing. Do you have anything else to add?
Well, just the learning experience of this for us has been twofold. The risk of Ebola will go away, but this has now made us aware that there's always going to be that potential risk of some other Ebola-like disease, so we have developed the infrastructure and systems to deal with it. So that's been good. The other is the importance of public health at home and the importance of public health departments and the role they serve in protecting the community.
Like Stony Brook Public Health.
There we are.
Yes, definitely. Public health is very important here at home and globally, and I very much agree. Do you have a final comment?
Well, it's just that the other lesson we've learned from this is that at a time when healthcare has often been a highly competitive enterprise and a very fractured enterprise, that this has provided a vehicle for how people can combine the public sector, the private sector, different health systems, find an issue that we can come together on and execute a solution. And I think it would be great if we could take the lesson from that and move on from Ebola to other items in the public health domain.
That is very true, because the amount of collaboration on this one issue is amazing. So if we could continue that and work on some of the other important, not that this isn't, but continue and work on other issues of the same importance in public health with that collaboration, that would be really a wonderful thing to see. And I think we could do it.
I think so too.
Yeah. Okay. Well, that concludes our show for today. I would like to thank my guest, Dr. Reuven Pasternak, the CEO of Stony Brook University Medical Center. And I just would like to thank you for coming here and discussing the importance of Ebola preparedness and response and what your hospital is doing to help with that. And I really thank you for joining me today.
Well, thank you for the opportunity. I enjoyed it.
Thank you. I want to take this opportunity to wish you all a happy Thanksgiving. Please join me in 2 weeks for another Your Health Matters. Thank you, and I wish you a safe and healthy day.